So I'll be giving the second part of the non-coronary cardiac findings, focusing on the cardiac valves and the pericardium. Then after me, James Lee will come up and he'll talk a little bit about structural heart disease as a whole. And if there's something, honestly, that I was not anticipating when I did my training, longer ago now than I care to remember, when I trained in cardiovascular CT and cardiovascular MRI, I honestly believed I was going to go out into practice and I was going to do coronary CT angiography for the evaluation of ischemic heart disease, and I was going to perform cardiac MRI for viability assessment. That's what I thought I was going to do as a part of my career. It's not that I don't do those things, but so much of what we do in cardiovascular imaging, specifically CT and MRI, is outside of the realm that I expected it to be. And structural heart disease is one of those real revolutions that is occurring. And if you aren't very involved in this, or if this is something you don't do at your site, or you're thinking about getting involved, as a couple of the people I've talked to over the course of this session, I would encourage you to do it. There's a tremendous amount that cardiac CT has to add to the practice of medicine with regard to the evaluation of structural heart disease. It's an incredibly exciting time for us in the field of cardiac CT. And as you know, you can tell that from looking at the program for our annual scientific meeting. The program is simply full of lectures talking about structural heart disease. So I want to provide a little bit of a framework for that. As I mentioned, we'll be talking specifically about valvular heart disease assessment with CT, and then also CT of the pericardium. And when we look at the various different things, again, starting out with valvular disease, we'll talk a little bit about the role of CT, because as with so many things, what we have to offer for our patients in the evaluation of cardiac valvular disease is pretty specific. And cardiac CT is a complementary modality to the other more established modalities, cardiac MRI and certainly echocardiography for valvular heart disease evaluation. We'll look at the role of CT. We'll talk a little bit about the normal anatomy, things that you may be used to looking at, structures you may be used to looking at on echocardiography, and what do they look like when we view them through the lens of CT. Then we'll talk about the abnormalities that we expect to see, stenosis, regurgitation, insufficiency, and we'll spend a little bit of extra time talking about valvular prostheses, like the movie that you're seeing here as well. Just like with my last lecture, I'd like to acknowledge before I begin the contributions of Chris Maroulis. He gave this talk, or one very similar to it, last year, and a lot of the content, including this movie, is his. So when we think about the evaluation of cardiac valvular disease using CT, you can kind of think of it as a schema like this. The aortic valve is huge, right? Of course, you're all well aware of the revolution in TAVR that's occurred and is largely enabled by CT evaluation of the aortic valve. Following somewhat closely behind the aortic valve is the mitral valve. We're starting to do more CT of the mitral valve for evaluation, in some cases for planning of a transcatheter mitral valve prosthesis, but just honestly in general terms for the mitral valve. A little bit further behind this, I think the tricuspid valve is looming in the future, right? We've started to do a little bit of tricuspid valve CT at our institution. The pulmonic valve, unless you're a site that is part of the Harmony trial or the Melody trial, you may or may not see a lot of pulmonic or pulmonary valve CT. Again, there's some individual variation, but in general, this is kind of our strata, our hierarchy, if you will, of the evaluation. So if you work in echocardiography, you know that echo is the premier way to evaluate the cardiac valves. There are some ways in which multi-detector CT is complementary to it. With regard to safety, it's hard to argue against echocardiography. There's no ionizing radiation involved with cardiac ultrasound. So that, I would argue, that's an advantage of echocardiography as compared to CT. With regard to anatomic data, this is kind of a funny thing, right? They both get a check mark on this particular grading system, right? Anatomic data, if you're talking about the leaflets, it's hard to beat sound waves, right, when it comes to the way that we evaluate the valve leaflets. We do not do as good a job with CT looking at the leaflets themselves. But when you think about the anatomic milieu, right, the environment, the cardiac skeleton that the valves live in, CT does a pretty nice job, right? Volumetric acquisition, isotropic voxels, the ability to orient in any plane after the patient's gone home. There's a lot of anatomic detail that's available on CT. That's a real strength of the modality. So both of those groups get a check mark. Blood flow data, at least as of the current moment, we can't generate flow information on CT, right? So obviously echo wins that battle. You probably are aware, right, that there is some idea that there may be some things we can do for the evaluation of flow data using CT, but that right now it's still in the research realm. Left-sided cardiac valves, again, same comparison we've already talked about. Right-sided cardiac valves, if you do echo, you know that sonographic windows can be a bit of an issue on the right side of the heart. CT, honestly, depending on how you do your contrast administration, CT doesn't care which side of the heart you're on, right? It does not particularly make a difference. Right-sided cardiac chambers, left-sided cardiac chambers, they're all visible using CT. Spatial resolution, both of these techniques are pretty good. Temporal resolution, echo is the winner by a pretty substantial margin. Speaking of temporal resolution, these are the things about cardiac CT that make evaluation of the cardiac valves a challenge. When you think about the temporal resolution of echocardiography, 33 milliseconds, the best CT acquisitions that we have, giving up multi-sector reformations and things like that, honestly, real-time, true temporal resolution of CT, you're not going to do much better than 60 milliseconds. So echo is clearly the winner there. With regard to irregular rhythms, what does an echo care? If you've got an irregular rhythm, it might be a little tough to see, but most of the time, honestly, you're going to be able to follow with sound waves. But irregular rhythms, issues with variability of heart rate, issues with cardiac gating, right? These are a real bugaboo for us in CT. Also, I personally love to smear and slander echo when it comes to artifacts and difficulty getting sonographic windows, but many of the same factors that can make echocardiography challenging can render cardiac CT challenging as well. Obesity, right? The bigger patients are, the more difficult it is to get the photon beam to penetrate all the way through the entire volume of the patient. Calcium is an issue, I would argue, and you'll hear me argue in the course of the next hour, that CT is in fact the best test. It's the diagnostic imaging test of choice for the evaluation of calcium. But dense calcification can be a problem for us in CT, and you've already seen examples of that so far. Also metallic leads, again, hard to beat CT in terms of identifying that they're there, but metallic leads, particularly moving metallic leads, can cause artifacts, and we'll talk about that as we go. Motion artifacts are, obviously, we've already talked about. So there are limitations for CT, and yet the exquisite anatomic detail that's available with CT really makes it good technique for the evaluation, at least a good adjunct technique for the evaluation of cardiac valvular disease. Here you see these are cases that Chris has loaned me. On the left, a unicuspid aortic valve. You can see very nicely the outline of the raphe in that regard. And then on the right, the somewhat rare quadricuspid aortic valve, very, very nicely delineated on CT, albeit on a still frame image. The strength of CT is in its anatomic detail and the ability to identify the structures that lie right around outside the cardiac valves. Okay, and again, this is our hierarchy. As you know, the aortic valve and the mitral valve are left-sided cardiac structures. Your general coronary CT acquisition can be modified very slightly for really nice evaluation of the left-sided cardiac valves. Well, what about the right side of the heart? You remember I put Chris Maroulis on the spot when he was here, where you're washing out the right side of the heart. We saw some cases yesterday where the right side of the heart was so washed out by saline that it was very difficult even to see the interventricular septum. If you don't opacify the right-sided cardiac chambers, you're going to have a really tough time evaluating the tricuspid valve, right? That's going to be a challenge. So when we design protocols to look at the right-sided cardiac structures, we basically perform what is essentially an ECG-gated PECT. we happen to have, right? We're a referral center for pulmonary hypertension and chronic thromboembolic disease of the pulmonary arteries. So we have an ECG-gated protocol that we use for evaluation of the pulmonary arteries when we're trying to look at RV function, when we're trying to look at which patients are suitable candidates for a pulmonary thromboendarterectomy procedure. So that's what is essentially a PECT performed with ECG gating can be adapted very easily, right? The right-sided cardiac injections that we use for PECT can be very nicely adapted to look at the tricuspid valve and the pulmonary valve. So this is it's not particularly a challenge. As Dr. Carr mentioned yesterday, it can be difficult to opacify the pulmonary arteries depending on what patients' breath holds are. But honestly, doing an ECG-gated CT looking at the tricuspid valve and the pulmonary valve isn't any more difficult than doing PECT. It's something that most of us in this room already have some experience with. So this is certainly possible to do. When you're evaluating valves on both sides of the heart, that's when we begin to think a little bit about what's going to be tricky about this examination from a technical perspective. Normally what we do at our institution is what Dr. Shapiro alluded to yesterday, and we try to build a coronary CT angiography acquisition protocol with a mixed flush, so not a pure saline flush, but maybe a 50-50 or a 70-30 blend, so we still get adequate opacification of the right-sided cardiac chambers as well as left-sided cardiac opacification. If you have more technical questions, I'm happy to answer them afterwards or in the question and answer session. Okay, so this is kind of our granddaddy, right? This is the first valve that we look at and think about. This is where most of the work is. This is where most of the studies are. It's honestly where most of the volume is in our practice. We do about 5 TAVR CTs a day. It's not a fun day, honestly. The TAVR CTs, as you know, take a long, long time to perform. But if we would open the floodgates, right, I'm confident we could do twice as much volume in this area. This is a major source of volume looking at the aortic valve for us, and we'll hear more from Dr. Lee coming up on that. With regard to anatomy, we think of this as called the so-called triradiate crown, which is our pathology colleagues talk about it. We're looking at the sinuses of Valsalva, which of course, as you know, are the left sinus, the right sinus, and the non-coronary sinus or the posterior aortic sinus. Lots of different names for these structures. Right, this is what they look like on CT. Honestly, that's a prettier image there. Anyway, and that's in the absence of contrast, right? Ability to visualize very nicely the aortic root structures. The cusps and leaflets correspond to the sinuses, left cusp, right cusp, and non-coronary cusp. It's always been interesting to me, right, that the aortic valve and the pulmonic valve have cusps, right, and the bicuspid valve and the tricuspid valve have leaflets. I don't know, it seems weird to me, but these are, according to our pathology colleagues, the valve leaflets and the aortic valve are more appropriately called cusps. Commissures, as you know, are those corners, right, where the valves come together, and you see in the yellow there the outline of the leading edge, the touching edge, the contact edge of the cusps from the right and the left, the right and the non-coronary sinus and the non and left sinus. Again, that's in patients without disease. When we look at and evaluate the aortic valve, we also want to evaluate the adjacent root structures. The left ventricular outflow tract is not honestly a part of the aortic root, but its adjacency makes it important to us. We do measure it that way. This is obviously something that's evaluated on a routine basis with echocardiography. Right above the left ventricular outflow tract is the aortic annulus. Just above the annulus is the level of the sinuses of Valsalva we've already discussed, and then the sinotubular junction. So if you evaluate those 4 things, right, those 4 evaluations and measurements are part of our routine evaluation of the aortic root, and we do that on every case. These are the structures that we look at on every case. With regard to, again, the strengths of cardiac CT and the role of cardiac CT in the evaluation of this disease, we can assess cusp mobility, maybe in a native valve, maybe kind of close to as well as echo. We can evaluate calcification of the aortic root and the aortic cusps better than any other imaging modality, quite frankly. And we can also evaluate the morphology in all the cardiac phases. Multi-detector CT imaging provides complementary imaging to echocardiography and And we know that from studies that have been done, right? This is just, as you can see on the left side of that graph, MDCT evaluation of aortic valve area versus TEE evaluation of aortic valve area. This was in a series of stenotic patients. We can see that those data are well correlated. So how do we do this? Again, from a technical standpoint, when we measure the orifice area in aortic stenosis cases, what we're looking for is the systolic phase with the greatest valve opening and the least motion artifact. And this is important because if you can't reproduce a measurement, right, if you don't have adequate image quality to reproduce a measurement, then you honestly aren't going to be able to make an accurate measurement time and time again. So what we look at, right, is we normally do multiphasic examinations and we watch the heart pump and we watch the valve open. Most of the time, that point of maximum valve opening occurs in mid-late systole, around 20%, maybe 25% of the R interval, 50 to 100 or 150 milliseconds after the R wave peak. And I'll show you specific examples of how we actually do that. As you know, we borrowed from echo in this regard, aortic valve area.